my pleasure to be here in this scientific session to present a case report in front of the learned audience. Today I am going to present a case report that a cardiovascular surgeon faces once in a blue moon. And the topic is surgical management for a stuck-up and fracture angioplasty devices in vivo during PCI in a complex LED artery lesion. A case report and literature review. Introduction. In vivo entrapment, fracture and retention of angioplasty hardware during percutaneous coronary intervention are rare. However, they may lead to a grave sequelae like intracoronary or systemic embolization, thrombus formation, emergent coronary artery bypass grafting, or death. In recent years, the incidence of loss of angioplasty hardware during PCI has significantly lessened from 8.3% to 0.21%, probably due to advancement in technology, device designing with the universal use of pre-mounted stands. Although various non-surgical retrieval approaches of unexpanded stand have been carried out with a success rate as high as 86%, surgical removal can still be required in a few cases. Making a prompt decision and planning for managing this type of complication is always essential. Here is the case summary. A 59-year-old diabetic hypertensive gentleman has attended the emergency room with the typical features of angina pectoris for more than 2 hours. On physical assessment, the patient was hemodynamically stable. The patient was evaluated with 12-lead electrocardiogram and high-sensitive troponin cardiac biomarker, where it is revealed more than 14,000 nanogram per liter of blood. And this ECG showed ST segment innervation in V1 to V3 chest lead. So from clinical and non-invasive diagnostic investigation, the patient was diagnosed as a case of acute ST segment elevation myocardial infarction, and we initially managed him with a thrombolytic agent in the emergency room. The following day, he underwent a CEG to check his coronary artery status, which demonstrated that essentially single vessel disease. And this is the angiogram view of that patient, where it shows the proximal LAD has got calcified lesion and has 90 to 99% narrowing in its proximal segment, followed by diffuse disease throughout its length and its branch vessels. On account of this, urgent PCI was recommended. And during PCI, a stent was deployed in the proximal LAD. And after that, check angiogram revealed proximal LAD is well dilated. However, mid LAD showing long dissection with interrupted distal flow. To overcome this situation, a stent was tried to approach in the mid LAD and tried to deploy it in the mid LAD, but it didn't cross the mid LAD lesion. And at the time of withdrawal, it was stuck in already stented proximal LAD lesion and calcified lesion, when it is tried to pull it out, the delivery shaft was broken. Immediately, a non-surgical retrieval was tried by snaring, but it was failed, and then it was left in vivo. So prompt decision was made for surgical retrieval, and we operate this patient on-pump arrestor technique, and we do an open endarterectomy in the LAD and diagonal branches, and then this large atheromatous plaque was removed from the LAD and diagonal and septal branch. Then this long delivery shaft was removed from the LAD and aorta with stuck stent. Now after that, LAD and diagonal arteriotomy was reconstructed with large onlay venous conduit. And we follow up the patient after 6 weeks of surgery, where it is demonstrated that improvement in NIHA functional class from 2 to 1 with resolving ST segment elevation in V1 to V3 lead with T inversion, and also improvement in ejection fraction from 38 to 47%. Here is the discussion. The incidence of broken retained coronary angioplasty hardware is around 0.2%. However, these incidents have significantly downtrend in recent years, which might be due to the improvement in technology and device designing. Among the angioplasty device losses, the stand loss was most frequent, and that event is commonly occurred during the attempt of delivering a stand through a previously deployed stand, or during stand balloon assembly was pulled back into the guiding catheter before reaching the target lesion. Contributing factor for fracture angioplasty hardware and failed deployment of the stent in current cases were most likely due to calcified tight coronary lesion involving branch vessels, hardware reuse, and polymer aging. Navigation of the catheter through a narrow calcified coronary might cause trauma, and it was observed in this reported case. To manage that event, a stent was attempted to be deployed with a prior building, but it was failed. Although various techniques of percutaneous retrieval of coronary angioplasty hardware are available, it has become a preferred procedure, being more appealing and minimally invasive. In this reported case, it was attempted but unfortunately failed. Herein, we considered surgical retrieval and coronary revascularization with open coronary endarterectomy with only bypass grafting. Coronary angioplasty hardware should be handled gently, carefully, strictly according to the manufacturer instruction for use, and it should be checked for its integrity once it's taken out of the body of the patient. In vivo entrapment of angioplasty hardware, fracture and retention during PCI are rare. In those cases, it will be critical to fully inform the patient regarding the risk of the procedure and consider surgical revascularization. Thank you. Thanks for your patient hearing.
Now question answer session, please.